PCSK9s have now been a tremendous news item for the last few years, but I'll tell you, with the new guidelines, a lack of targets, what kind of role are they going to have in the world once they get approved? Some great pieces of information have been released at this particular meeting of the American Heart Association. I'm with Patrick Moriarty, who's a professor of medicine at Kansas University Medical School. Now, in this particular case, we're talking about alirocumab.
Yes.
And this particular trial is looking at patients who really are intolerant to statins?
That's correct. They had to have at least 2 or more statin intolerance. And one of the statins had to be the lowest dose to qualify for the study. And their intolerance had to be related to musculoskeletal symptoms.
Now, there is a place right there where PCSK9 inhibitors obviously will have a role.
Hopefully, yes, yes.
So tell me about the patients, tell me about what you found.
Well, this patient population, besides having statin intolerance, they are very high risk. Over 50% of them had cardiovascular disease, and the mean baseline LDL was 190. So the primary endpoint was looking at the difference of efficacy between ezetimibe, which is usually used in this patient population, to alirocumab in the sense of LDL reduction. And to validate their complexity, which this patient population is, because it's up to 25% of patients who try statins have some form of intolerance. Actually, in my clinic, the patients referred to us, over 50% of them have statin intolerance, and that's why the reason I see them. Now, we had 3 separate arms of validation. The first arm was, for 4 weeks, there was a double-blinded placebo at control group in this, meaning everyone got placebo, either injectable placebo or pill, and we had a dropout rate of 13%. And the majority of them dropped out because of myalgias. Then we had a 24-week blinded 3 separate groups, one of alirocumab 75 to 150, depending on their goal of LDL after 12 weeks. Another arm was the ezetimibe with a sham injection, subcutaneous. And the third arm was another validating arm, which was atorvastatin 20 milligrams QD. After this 24-week period, we had another validating arm, in a sense, where everyone was allowed to take alirocumab for a 3-year period, and we did interim analysis of that. So the primary endpoint showed, 1, that alirocumab, in intention to treat, lowered LDL by 45%. And half of those patients needed titration up to 150 milligrams. In comparison, ezetimibe lowered LDL by about 15%, which you would expect. Significant difference. And the atorvastatin arm in that group, they lowered it by 32%. Now, safety. 80% of everybody in these 3 groups complained of some form of AE. In the patients that withdrew, it was between 18% in the alirocumab up to 25% in the atorvastatin arm, with discontinued the drug. And there was no significant difference in those 3 groups, even though there was a trend towards alirocumab being better. Now, when we looked specifically at myalgias, there was a significant difference, meaning there was less people complaining of myalgias on alirocumab compared to atorvastatin by 0.042. But despite that, the dropout rate for myalgias was still non-significant, even though there was a trend towards alirocumab. Finally, in the open label, where 90% of patients that participate in the trial continue in the open label, the dropout rate on alirocumab so far has been less than 3%.
Wow. So what's the take-home message?
The take-home message is
positive message
that alirocumab in this patient population is effective, very potent, and it appears safer than atorvastatin and somewhat safer than ezetimibe. But if in open label, if you look at it, patients who are 100% intolerant to statin, in the open label, 97% of them can tolerate alirocumab without adverse side effects.
Is there a mechanism to explain why they're not having the kind of effects they get with statins? What's the difference between the...
If I knew that mechanism, I'd be talking to you from the Nobel Prize in Sweden. No, there is no, we don't know. That's the complexity of these patients, and this is why I get referred them to my clinic, because we don't have a definitive answer. And they're very difficult to treat, but they exist in every clinic that treats patients with lipid complications.
Well, it's really nice to know that there might be an alternative for these patients fairly soon. And for CardioSource World News, we have a variety of stories from this meeting, many of which happen to be on PCSK9s, but certainly not all. Please see the December cover story for CardioSource World News. I'm Executive Editor Rick McGuire.